Good morning, good afternoon, good evening, wherever you are in the world. Thank you so much for joining us. You are joining the COVID-19 webinar, How a Novel Infectious Disease Impacts Local, Global, and Future Health. This is brought to you today by the Yale Alumni Association Shared Interest Groups. My name is Stephanie Double. I'm a director for the Shared Interest Groups at the YAA. We are doing this webinar in partnership with the Yale Alumni Health Network, the Yale School of Public Health, and Yale Health. So we're going to hear from a number of experts today. Our chair of the Yale Alumni Health Network is Dr. Jamie Wells, Yale College class of '96. Jamie has published over 400 articles on as a director of medicine for an educational advocacy nonprofit in support of evidence-based medicine and science, and she writes, speaks, and is interviewed as a medical expert in multimedia platforms. She is currently adjunct professor at Drexel University's School of Biomedical Engineering Science and Health Systems, which is the nation's first program in pediatric engineering. Without further ado, I'm going to turn this over to the amazing Dr. Jamie Wells.
Thank you so much, Stephanie and YAA and all of the participants on the panel today. We're very excited. We hope a serious tone, but be able to enjoy this a bit and calm some fears, assuage any panic, that's for sure. And our goal is to increase the information, debunk myths in this hour. The Yale Alumni Health Network, or YAN, our mission is to break down silos in the health-related disciplines to spur innovation. So albeit from a biomedical engineering perspective, medical practitioners, epidemiologists, health law, health policy, we want to break down those silos, be a nexus between the disciplines, because it's those knowledge gaps that sometimes perpetuate misinformation and also can be a key source of innovative solutions. So I am thrilled that we have a wonderful panel today. Hopefully we will do some good in furthering the spread of wonderful information and modes and methods for you all to participate, because I know people are chomping at the bit at ways they can help, and everybody can pitch in to do so. So without further ado, before I kick it off to my speakers, my wonderful speakers today, we have held a sold-out, Jan has held a sold-out event in New York City with Dean Kamen. We're planning on doing future other in-person events. I'm very hopeful they will be down the line, but they will resume again. And we also will be doing, because of the high demand today, a recurrent series on these kinds of things and using remote learning and webinars to do so. First, I'm going to introduce the speakers. They're going to speak for about 5 minutes each, and then we are going to open to questions. So feel free to utilize the question bar to do that. So without further ado, one of our rock stars today is on the front lines of the current crisis. Dr. Cindy Ho is a Yale graduate. She is an infectious disease physician. She serves as the infection control officer of her health system at Jefferson Health, New Jersey. So she is in direct contact with the Department of Health, creating policies that are changing every minute. It seems these days. She is an active practitioner. Dr. Ho is also a physician champion for New Jersey Hospital Association's Antimicrobial Stewardship Collective and an advisory board member of the Sepsis Alliance. Her knowledge is vast in this field, and she is going to address what it is that she does and what the psychosocial effects of COVID-19 are. So Dr. Ho, take it away.
Hello, everybody. I want to break the ice and give you a virtual fist bump. So, hello. And good morning, good afternoon, good evening, wherever you are. It's great to be here, and thank you so much for Jamie Wells for the invite and the Yale Network and everything. So as Jamie said, I am an infectious disease physician, and I do infection control for Jefferson Health, New Jersey, and also our ambulatory sites with Jefferson Medical Group. Having said that, today what I'll say is basically kind of my opinion and does not reflect any of those two entities. And I really am on the front lines. So our institution, like many of yours, have probably received COVID-19 patients, or what we call rule out COVID-19 patients. So I really am on there on the front lines. But the truth is that there are many front lines in this effort. And today I really want to talk a little about the psychosocial impact of COVID-19, because I've really found that it impacts everyone and people that you may not have even considered before. And I guess I'll start with the healthcare setting. You know, the situation is already very stressful when you look at things, maybe look at the TV or media too often. There's a certain threshold where you need to get information and of course, reputable information. At the same time, you can't do too much, because then you get into this state of worry and anxiety about everything. And I found that can sometimes occur to the healthcare workers, our own doctors, our nurses, even techs, the environmental service workers, everyone, because, you know, there's a worry in cases where a patient comes in and they're being kind of ruled out for COVID-19, and the pulse of the people is that they're really concerned whether they're inadvertently going to bring home anything to potentially expose their own families. And sometimes what you might hear of all over the States is whether the healthcare worker might even be separating their own families, and they might relocate some of their parents or their children to elsewhere because they're just really concerned. And I think for those of us who work in whatever health setting, it's an opportunity unlike any other, where every day we have to ask each other, how are you? And you know, to take a sense of the pulse of the people. But it's an intense environment to begin with, and perhaps only going to become more intense as we try to tackle and manage the everyday people that come into our healthcare settings, let alone when there might be the potential for even more serious cases of the COVID-19 patients. And then when you talk about the healthcare setting, there's the patients themselves. And I'm not just referring to the people who are in strict isolation. Just imagine if you were quarantined, not in the large confines of your apartment or your house or condo or wherever you may live, but really in a room in the hospital setting, and you're quarantined for however long until the medical therapy is done. And so, you know, we have to consider the patients who are infected, whether there's a role for any kind of behavioral health specialist, a psychologist, a psychiatrist, and to check in with the patient about how they feel, those who are infected. And honestly, it's also those who are not infected. You know, there may be settings where there are nursing homes. It's an opportunity for those who have the fortune of having kids or grandkids, or even if you're an adult, it's a chance to write a note, a simple hello, a simple card to those who are confined because they can't have visitors. It's very common these days for healthcare settings not to have any visitors. Just imagine the thought of the fact that it's just isolating to be isolated. And these are the times where we need to reach out to each other to improve our perhaps our unknown needs from a psychological standpoint. And it's also a time for those of us who are maybe not directly in the care of health of patients to be involved in other ways, that each of us can find a way somehow, whether it's to help those who are not in school that might need school lunches or school breakfast or even whatnot, and a chance for congregate settings to really help out in a community in whatever way that we can. You hear many stories of this where it's simply neighbors helping neighbors, really, that in this day and time when it's strongly suggested to social distance, what can we do for our neighbors that they may not be infected at all, but they're elderly? Do they need help with day-to-day activities? Do they need help with groceries? There's just so many things that I think are so important that I had never previously thought about in a situation like this, at least in my lifetime. You know, this is hopefully once in a lifetime, but there are many things that each one of us can do to improve the psychological needs of each one of us. And even if it's admitted or not admitted, each of us has a pulse that has to be looked into.
Thank you so much, Dr. Ho. We're going to circle back to you, but we want to introduce our next panelist, Dr. Saad Omer, who is the inaugural director of the Yale Institute for Global Health, professor of medicine and epidemiology at Yale University in the School of Medicine and the School of Public Health. And he's going to do us all a favor to explain what epidemiology is, because you're hearing, a lot of the public is hearing about epidemiologists. Believe it or not, we all have different perspectives when we're in medical practice versus epidemiology. But hopefully they are never malaligned in terms of our pursuits. So he's going to expand on that a little bit. He has extensively studied and done research on efficacy and safety of maternal and or infant influenza, pertussis, polio, measles, and pneumococcal vaccines. He's experimented and done trials in drug regimens to reduce maternal to child transmission of HIV. So he is quite a knowledgeable viral hunter, I would say. And so I'm going to flip it over to you, Dr. Omer, and he is going to speak to how we got here and where we're going.
So thank you. So as it's well known that the virus was initially identified in Wuhan, China. Some of the initial cases from this seafood market, but we are not sure that it's actually the zoonosis event, the event of this virus jumping from an animal, I'll come to that in a second, to humans came from that specific market. But there was usually initially that you identify a cluster of people there. We think a single event of a virus jumping from an animal to human happened in early December or late November. By around mid to late December, the Chinese authorities, local authorities started seeing an uptick in pneumonia cases, unusual pneumonia cases. And by December 31st, they identified the World Health Organization. This is, and then, the rest is history. The world has been seeing these cases emerge and explode and introduced into, I think the last count was between 150 and 160 countries now have an importation of this virus, or they have the virus identified in these countries. The US, unfortunately, of the 353,000 cases, a little over 353,000 cases, the US is the third highest, has the third highest number of cases among all countries, followed by China, Italy, and Italy. And the way that our outbreak is going, we're likely to surpass Italy fairly soon. We currently have 35,500 reported cases as of 11:44 a.m. this morning. The cases, obviously, they're reported in batches, and we are likely to see more cases here. Where does this virus come from? It's a bat virus. We know bats have a lot of viruses out there that often jump to other species. We think that it came through an intermediate species. And it's not a direct transmission to human. So that's what we know. What the intermediate species was, excuse me. As you saw, I used my cough etiquette.
I was going to applaud you for that.
So
Yeah, Saad doesn't have COVID-19, just so everybody's aware of that.
Yeah,
Okay, we're good. We're good.
So we have, we know that this virus came from a mammalian origin. It's from a bat virus that passed through another species. So how infective or how transmittable this virus is? So the way we measure, the way we quantify the transmittability of a virus is called R0 or R0, which is a simple concept. It is, if you go into a population where nobody is immune, and if you introduce one case, how many different individuals will be infected from that one case? And the R0 or R0 of this virus is between 2.2 and 2.7. The estimates vary early in the outbreaks. Just to give you a comparison, measles is way more infective. For example, it's 12 to 15. SARS is close to between 2 and 3, and Ebola was 2 in terms of this value of, on average, how many secondary cases appeared if you introduce one case. So it is transmittable. It has relatively short serial interval, in a sense that the average time between two successive cases, and therefore it has a pretty high doubling time of the outbreak, in a sense that if a transmission takes hold, the increase happens rather quickly once you have testing, and that's what you're seeing. We know that there's human-to-human transmission. On the good news side, from the limited data that are available, there is little evidence of a vertical transmission of this virus. But we do know that there is evidence of asymptomatic transmission, but it's likely that the transmission, even if it's happening a couple of days before, 2 to 3 days before the symptom onset, that's why we sometimes quarantine asymptomatic people. So quarantine is for asymptomatic people. Isolation is for symptomatic people, so that's a difference in terminology. That's why we sometimes quarantine people even when they're asymptomatic. But most of the transmission still occurs right after the onset of symptoms. So just to put that in context. So this is the big picture of the virus. We know that we have cases. There is plenty of evidence. There is well-established community transmission of this virus in the US. The good thing is that, it's not that we are helpless observers in the face of this unfolding event. There are a lot of things we can do, both as individual and as a society, even short of having a vaccine, which is obviously the end game of controlling this outbreak, and there are efforts going on there. So personal hygiene, etc., hand washing it's based on evidence. It does reduce the probability. Social distancing, staying at home. Previously, when folks, most states now are asking everyone to stay at home, but previously the recommendation was to stay at home if you have symptoms. So those who don't have the option of not staying at home, like healthcare workers, they're going in every day. Even they have the restriction of staying at home in most places if they have symptoms, etc. And these are some of the strategies at the societal level. We can get into what societies can do as they strike a balance between the epidemiological advantages and social impact of some of these restrictions, because both of these things are important. So I'll pause here and would love to.
Thank you so much. And for the audience, we're going to go into a question answer mode after we introduce our final speakers, just so everyone's informed as to the different perspectives and approaches, and we get a more comprehensive view of this issue. So we will get into transmission, testing, treatment, a lot of questions coming in with regard to those things, asynchronous geographical isolating, different things we're gonna hit. So before we do that, we have one final speaker. So I'm not going to say saving the best for last because all of our speakers are rock stars today, but Dr. Dorothyann van Rhijn is the Chief of Employee Health at Yale University. She trained in primary care, started at Yale Health treating patients in acute injury and occupational health. She has been the Chief of the Employee Health Department for the university for many years, served on numerous university level committees, including the Biological Safety Committee. She chairs the Infection Control Committee for Yale Health, has an interest in zoonotic disease and the intersection of animal and human health, and has an extensive background. And she is going to speak now about what she's doing and what they're doing in the community up in New Haven. So thank you, Dr. Van Rhijn.
Thank you, Jamie. So my role as the Chief of Employee Health, we are very involved with the reporting and the contact tracing of the cases in the Yale community. So this week is a very different situation than it was about 2 weeks ago when we didn't have any cases in New Haven. And like most of us, I think we've been very busy trying to identify new cases and report them and do some contact tracing. One of the surprising things that's come out of this is that there's been a really wonderful amount of collaboration between all of the schools at the university. So Yale Health, Yale School of Medicine, School of Epidemiology, the nursing school, in addition, the hospitals, Yale New Haven Hospital, and also the New England Medical Group, which is a private group associated with the university. We've all really come together to respond to this pandemic, and people are sharing protocols. They're looking at staff. They're looking at where they can redeploy staff. They're looking at student trainees who may be able to be sent to various places to do roles that would be applicable to their level of training. So it's been a great community response in terms of trying to help everybody and keep the community safe. Currently, what we're doing now is, although many of the health departments have actually given up on contact tracing, we have many cases here, but we don't have as many as New York City, for instance. So we're still working with the department or with the School of Epidemiology and trying to look at the high-risk contacts of the known cases so that we can reach out and identify them and ask them to self-isolate. So that's been one of our main focuses for the last week. Currently, epidemiology has a number of student volunteers that are helping them in this effort, and it's been a really wonderful collaboration. We've also been working with Yale Haven Hospital to set up drive-through testing sites. So I think everybody's heard that testing was somewhat of a challenge initially because it could only be done through the state departments of health, and there were a limited number of test kits. We actually have a better situation now, although I think it could still be improved. But now that we have some commercial partners, we can do more testing, and so we have several drive-through testing sites. And recently, the end of last week, we took one of the Yale employee parking garages and we've turned that into a drive-through testing site. And the hospital has some in other locations over the state as well. We do hear that there's supposedly going to be a point of care test on the horizon at some point, but it's a little too soon to say how that will be used and when it would be available to us. One of the other things the university is doing that's really exciting is we've taken one of the sections of the gym, we call it the Landman Center, and we're setting up an auxiliary treatment center there. And we'll have space for anywhere between 25 and 50 patients to start out. And these would be patients that were not sick enough to be hospitalized, but for whatever reason, not able to go back to their homes to be monitored. So that's been a huge effort in terms of mobilizing staff and equipment and space and getting set up. We have a big partnership with the environmental health and safety folks at the university. They've been training us in how to use the personal protective equipment so that all the healthcare workers know how to use it, because it's not enough to have the equipment. We actually have to make sure that we put it on properly and take it off properly so that we don't contaminate ourselves or another patient. And they've been working with us on decontamination techniques. And also, because of the shortage of some of the respirator masks, they've been able to procure a couple types of respirators with a hood that can be decontaminated and reused. So that is a very promising situation for us.
I'm going to say thank you so much. And I want the viewers to know that we already talked about, I feel like with these, it's like I'm not a professional anchor, but I do want to get everybody's questions. We're getting inundated with questions, which is a wonderful thing. So we want to answer as many as we possibly can. So all of the speakers already know if I interrupt them, it's meant to be polite. But so one of the first things I want to pivot to is transmission. I'm getting a lot of questions with respect to there are reports that there are respiratory droplets, and then there's also the fecal-oral route. Are there different strains with respect to that? What did Dr. Omer mean by vertical transmission? How do we put this into context of SARS and MERS in terms of, is this going to be a one-off? So if we can have each of the speakers, maybe starting in the order that we did, Dr. Ho, with regard to transmission, people want to know, can they get it in a pool? How is it transmitted on surfaces versus elsewhere? So if we can touch briefly on that, that would be wonderful, followed by Dr. Omer and any additional thoughts thereafter.
Sure. So the basic two routes, which explains some of the things that all of us have been asked to do, is, you know, when you have to cover your cough, you're basically covering the nature of the cough from going outwards into the 6 feet realm. And so if you think about it that way, then one of the ways that it can be spread is droplets. So if I were infected and I coughed into my hand and I kind of put it on a surface, and then somebody else was very nearby, such as on public transit, maybe somebody else could get that as an example. So there's a droplet spread. And then there's the contact spread. So, and this is prolonged contact without what they call the PPE, or the personal protective equipment. This is a lot of the themes that you've heard probably all over the states of healthcare workers pleading for PPE for the purposes of protecting themselves when they are taking care of those who have the COVID-19. There are potentially other routes that the virus has been found, such as when COVID-19 patients historically or classically, you think of them having respiratory symptoms, they can also have GI or gastrointestinal type symptoms, such as abdominal pain and diarrhea. This is one modality of why feces are thought to be a potential for spread. So sometimes your local county may suggest having a separate bathroom if there are other people that live in the same household. And then, you know, sometimes that's not really possible. And so there are standardized ways of cleaning the bathroom from environmental protective agency type kinds of recommendations, such as with bleach and so forth. And so these are some of the considerations of the questions that you had asked.
Dr. Omer?
I think Dr. Hu covered it appropriately.
Wonderful. In terms of seasonal shifts, we're getting a lot of questions of which I'd love everybody to be able to interpret a crystal ball, but what are we looking at in terms of the next few months? Is society going to return to normal? Are we going to be semi-normal-ish for a couple-month period of time? Is there any kind of projection in terms of how these pandemics tend to go in terms of that?
So these are two separate questions. So there's a seasonal shift, and then how long can we be there? So I can answer the seasonal shift, and then sort of, if there's time, I can answer the second question as well, because they're separate questions. So for seasonal, so it's not an unfounded perspective. There are a lot of myths out there. This is not one of them. It's that it is that there is genuine uncertainty about how this virus will behave. And here's what we know from other viruses. So there are respiratory viruses like influenza, like respiratory syncytial virus, and other coronaviruses. So, you know, coronaviruses are with us. There are at least 3-4 that circulate pretty regularly that don't cause anything even close to SARS or MERS or COVID-19 kind of disease. And so there is a lot of seasonality for several respiratory viruses. But we would have been more certain, and with SARS, there was some evidence that some seasonal differential transmission played a role, although there were other factors in terms of controlling SARS that were probably more prominent. But the problem with this is that in 2009, when we had an influenza pandemic, which was a full-on pandemic, there was a new strain of influenza. Fortunately, it caused relatively low mortality. When we had the influenza pandemic, there was circulation going on during the summer as well at pretty decent levels. So here's my best educated guess based on the previous evidence that we could see a diminishing of transmission as the weather warms up, but we are not necessarily going to see a vanishing of this virus. So that's the take on the seasonal part.
Thank you so much. The question with regard to, there are a lot of questions coming in with regard to a potential herd immunity with the population getting it. There are a lot of questions with regard to, if you get it, can you be reinfected with it? Does anything along those lines for you, Dr. Van Rhijn?
You know, I think I'm going to pass to maybe Dr. Omer. I've seen one anecdotal report that you could possibly be reinfected, but I really can't comment too much on the herd immunity.
So there are two separate things, and I actually this time address both of them, but separately. So reinfection part is that, look, this is a 3-4 month old virus. That's 3.5 month old virus. We are still learning about it, and our knowledge has expanded with lightning speed. But we are still trying to understand the complete parameters of it. What is in our favor in terms of having at least medium-term immunity is that when they looked at antibodies, people who got infected mounted a decent response in terms of developing antibodies. We, at this point, do not know. It's actually one of the things that I am working on, is to find what we call a correlate of protection. What is the level of antibody at which you are protected? Because that's an important question for vaccine development. It's an important question for looking at what proportion of your population is protected, et cetera, and so on and so forth. What we do, there were a few reports, a couple of case reports that indicated that people who were released from the hospital then came back with symptoms. They had sort of a negative or two tests, and then they came back. That could be not necessarily a reinfection scenario. It could be that they had initially virus that was, these tests were being developed, et cetera, and it happened in situations where the health system was overwhelmed, that there were incentives to let people go home. It could be that it was an issue with the testing, not necessarily true reinfection. So at this point, based on what we know from other viruses, and based on what we know from the current data, it's reasonable to assume that at least in the short term and medium term, there will be immunity from this virus. We don't know about, so in a lot of viruses, the immunity goes away even without a mutation. It's not an influenza-like scenario that we are looking at, but even in viruses that do not mutate for, let's say, on an annual basis, you sometimes lose immunity to them. But it's not in weeks or months. It's a longer time frame that we are talking about. So in the medium term, I think it's reasonable to assume that we will have protection if you get it. But the science is evolving.
I'd like to pivot to Dr. Ho in terms of getting a lot of questions with regard to the efficacy or success of the actual treatment that people are recommending, or there are reports that there are benefits from in terms of the hydroxychloroquine plus azithromycin dose. Also, if you could touch upon the at-risk populations and the best things that they can do. For example, I've been asked by Susan G. Komen of Philadelphia, the CEO, their metastatic breast cancer community and breast cancer patients in the third and fourth stage of disease want to know what extra precautions that they can take. Being asked about pregnant women and the status of any newborns or babies who have coronavirus and being pregnant. So these would be in addition to elderly and other immune suppressed scenarios. But if you could address those two things about where we are with treatment, how promising it truly is, and recommendations for the at-risk populations I mentioned would be wonderful.
Sure. Well, as far as treatment, I think what everybody should know is that, it kind of depends on which stats you read, but around 80 to 85% of people, they recover completely on their own, just as you would with any other kind of respiratory tract infection. And you basically need supportive care, and whether it's some medication to reduce the fever, such as a Tylenol, such as hydrating yourself, supportive care and remaining at home and distancing yourself from those that you love so that your loved one at home doesn't get this infection. On the other hand, if you are sick enough to be hospitalized, these would be higher acuity, such as being short of breath and requiring oxygen. Some people may have chest discomfort or any kind of what we call alarm signals. And for these people, there are still what we would say supportive care, meaning a potentially a breathing treatment if one is short of breath, potentially the need for oxygen, potentially if one is dehydrated, then fluids. And then outside of this, you get into what's called investigational drugs. And what we should make clear is that there really is no FDA approved treatment at this time. There's certainly been a lot of discussion about potential therapies and studies in play and different institutions in the United States that have used particular drugs. And at least for what has been looked at is hydroxychloroquine, which has been studied and has shown to basically have some promise. But it wouldn't be for everybody because, again, 80% of people who have COVID-19, they completely recover on their own, never require anything. And so what is being discussed by physicians is the potential role for hydroxychloroquine in case of there's increased viral replication to try to help with COVID-19. There are certainly other medications that have been discussed, and they all have side effects, right? So the issue with hydroxychloroquine and azithromycin, the azithromycin is an antibiotic, and it also has different properties such as anti-inflammation. The problem with some medications is that they can increase what's called the QTC interval. And that can best be described as when you have an EKG, there's certain spots. So there's like kind of point A to point B. And if point A to point B is too long, that's not good, because then your heart rate can go into an arrhythmia. And we certainly don't want to make things worse than they already are. And also I personally, I don't feel that we still need data as far as a specific combination with the azithromycin. Outside of that, there are still many other experimental investigational drugs out there, and you know, whether they truly will work on an investigational scale, I can tell you that as a physician, sometimes one feels compelled to try something, especially if there are those who have COVID-19 have severely sick respiratory illness, such as they're on the ventilator and requiring a lot of oxygen. And as a physician, you always want to try something, even if it's investigational and may not be fully studied. As far as you know, an awareness of pregnancy and immunocompromise, these are certainly high-risk categories that you're more likely to get COVID-19, but you can certainly have a heightened awareness of how to protect yourself. And you know, these are particularly vulnerable populations anyway, and the I wouldn't want to call it the typical cancer patient, but you would imagine that cancer patients often times may already have a higher understanding of things like hand hygiene, because they may have, you know, the need for chemotherapy with a device that goes into their chest wall. So they're already thinking of heightened measures to prevent infection. And so one of the possibilities is with social distancing, washing your hands, you know, if there are certain errands that need to be done that would potentially be in a setting where you would be around crowds of people, such as in a grocery store, if you don't have the someone to kind of shop for you, or the ability to kind of get it from outside physical location stores, one can always ask for this. You know, certainly if somebody is, you know, you are potentially around somebody who is sick, you know, the sick person may be asked to put on a mask or to distance themselves from you. These are some general precautions, but even a greater heightened awareness. If these individuals need to go to their doctor's office, there are some doctor's offices, and more it seems, where hospitals, clinics, et cetera, are considering the role of telemedicine, so that you're able to connect with your physician without actually having to physically go out and about and potentially be around other people who may just have a common cold or the flu that, as your immunity wanes, that you may be susceptible to. As far as pregnancy and babies, I have not heard too much about babies themselves being infected from, but I anecdotally have heard of perhaps sometime after that when potentially they were exposed to an adult who was infected, and by means of contact, perhaps the younger individual might have gotten infected. But kind of leave it there, and perhaps if Dr. Omer has any further insights as well.
No, I think you covered it. And just this is to come back to what I meant by vertical transmission. That's what is meant by vertical transmission from mother to infant transmission. So that the reports we have seen do not indicate that that happens so far. The evidence is good. In terms of pregnant women being at additional risk, so yes, theoretically there could be at a high risk, but the data that has come out, which are very limited, have suggested that they are not at a higher risk of acquiring that infection. But again, this is theoretically there are higher, it is an immune altered state that pregnant women are in. So it's reasonable to be a little bit more careful.
There are also, I would add, recommendations if a mom were to test positive to separate the baby from the mother and things like that. So CDC has good information. There are a lot of organizations through the American Academy of Pediatric.aap.org or the American College of Obstetrician Gynecologists as well have their recommendations. So there's a lot of good, useful information. And I'm getting so many questions on so many topics, which is wonderful. So one of the things that I think I'm going to do, I'm going to try and get to as many as I can on this, but everyone can email me after this webinar concludes at Yale. My email is yalealumnihealthnetwork@gmail.com. And if you can email me your questions, if you'd like them directed at one of the specific panelists, then indicate that as well. And I will forward and get back to you with regard to any of the questions that have not been addressed at the end of this hour. So we will get to all of your questions. I do want to pivot because one of the greatest concerns, personally, professionally, societally, is this social distancing, this lockdown, everything in terms of that. It's affected, there are a lot of bioethical ramifications of that. Disease does not stop because there's coronavirus. So there are many people who were diagnosed with a cancer a week or two ago and their treatments are impaired. So I'd love to hear from the panel with regard to, every action has an equal and opposite reaction, and anything that we do can have unintended consequences. So there are a lot of discussions happening around between healthcare workers, the general public, and everyone in terms of, ostensibly it becomes a rationing of care. Are these huge interventions that we're doing in terms of calling society to a halt in the event that there is a case of this, especially since we're not going to ever be able fully to quantify what the effects of that are on premature deaths or worsening of disease that already exist, and other things like that, like we've discussed in terms of the emotional and psychosocial ramifications of a lot of the implementations. So if we can talk a little bit about the, no death, anybody wants no death in anything, but if we can put into context why some people consider referencing coronavirus to the flu as a false equivalence, touching upon these different concepts in bioethics of why we're doing such extreme measures here, because the ramifications can be quite vast in scope. So I'd love to hear everybody's opinion with regard to those kinds of issues.
Well, I can say a couple things about it. There are a lot of implications for social distancing or physical distancing, as Dr. Omer likes to reference it. Even though I think that, it's a hardship on people, I think that at the risk that the disease is progressing right now, we're at a risk of overwhelming the healthcare system. So I think that if we can decrease unnecessary social interaction, we'll actually have the resources available for the people who need it, such as the cancer patient who's been recently diagnosed, or the person who has a heart attack and needs to be, taken to the hospital and put into the ICU. So I think that for the rest of us, we don't need to go out to eat. We don't need to, go visit all of our friends. There's a lot of things that we don't need to do right now why this disease is ramping up to see whether or not we can at least slow the progression. I don't think any of us thinks it's going to stop completely because of this, but if we can slow the progression, then hopefully the healthcare system will be able to respond both to the sick patients with the coronavirus and also to the normal illnesses that society is going to have, because that doesn't stop. People still have babies, people still have heart attacks, people still get cancer.
So yeah, I think as you said, there is a trade-off, and it's an unfortunate trade-off that we find ourselves in this position. Outbreaks enter these exponential phase when we talk about not in terms of what is the number of cases we expect, we talk in terms of when the outbreak doubles. We are still testing not enough people to get the full size, but where the testing has been there doubled, the doubling time has been 3 to 5 days in terms of sort of in the exponential phase. Then it peaks for several reasons. One is that if you have impacted enough people, then they are at least transiently protected and so on and so forth, and then starts leveling off, or your measures are there. So, sorry. The question was that, is this an infinite period? So we know that at this point, it was because we were flying blind as a country for several weeks. We did not know who everyone's contact was, who presented in the hospital, etc. We did not have the tools or the manpower at the health department. If the health departments were saying that if we do contact tracing, meaning look at the person who's presenting at the hospital, go after their contact, how do we test them? Because we we are prioritizing tests for patients presenting at a certain level of disease, etc. So what is the long term? It is not sustainable for an infinite period, because even if there were no other competing health questions, which can be, in a way, you could argue that if the health system gets overwhelmed, people who are presenting with heart attack or a stroke are not going to get treated as well. So that mortality is actually, when people have modeled that, it's similar, et cetera, or even higher in an overflow kind of a situation. But even you set that aside, we are a society that values health, but there are other aspects of our social well-being, including the economy in and of itself. And people who have to go out and learn a daily wage, for example, waiters and those who work in certain industries, construction workers, and so on and so forth, we have to keep that in mind. And even otherwise, companies, when they continue to thrive, all of us benefit. So what do we do after you have social distancing that has an impact, that doesn't solve everything? So some of us have been thinking and modeling these things right after these things were put in place. The first thing is that there's no easy way out. The one way you deal with it is what some places like South Korea did, is that a person presents at the hospital, you trace that contact for everyone who presents at the hospital, for example, and then you go and test that contact. And then say, if that contact is positive, you isolate them. So isolation is for positive cases. And the other contacts that are not positive, you quarantine them. So quarantine is for those who are not symptomatic right now. So this is to cover the asymptomatic period as well, and future symptom development and that kind of stuff. And then you look at the contact that was positive and say, okay, are they positive or not? So you can easily see what is the problem currently. We don't have enough tests to go to that level of contact tracing. We don't have the manpower. And some of us think that a national level mobilization that has happened in other countries would be required to that level of aggressive contact tracing. Once you do that, you ramp it up to 75, 85%, then you can start safely easing off other restrictions. And it's not just the test part. We have a shortage of personal protective equipment. We have a shortage, which I never thought we'd have a shortage in this country of swabs in certain hospitals. And so if you want to use those swabs for sampling during contact tracing, that's the way to do this. So that's one thing. The other thing is the other aspects to minimize household level transmission. In Wuhan, after the restrictions were put in place, 79% of transmission happened in the household. Even in the US, in the first few hundred cases, the likelihood of household transmission is way higher than outside transmission. But we don't want to be in a situation where families are ostracizing family members. There are safe, evidence-based ways of contributing or caring for family members. CDC has a good set of guidance for that. It includes how to deal with the laundry, how to deal with provision of food, etc., while remaining compassionate towards our own family members. But that level of education is not there in the community. So we need to have that aspect covered. Once we have that, and this should be a strategy where we are buying time to put in place other things, that then at a certain level of that, we should be able to ease off some of the restrictions, but there will be at least some restrictions with us for a long term. And I don't think people mind having a few restrictions. The concerns are that a total or a near total shutdown has implications on people's not just livelihoods, but also lives as well.
Absolutely. It increases stress response, which suppresses your immunity, and it's a trajectory that We don't want people going down, and many are anyway in terms of that. I'm getting a lot of questions with regard to, there are many schools of thought with regard to testing as some panacea. Can we get a brief response of why testing is being constantly shifted in terms of the life cycle in the hospital versus these now testing centers on drive-through testing centers, and why the policy keeps changing? Maybe Dr. Ho, you can weigh in on that quickly.
Yeah, sure. Well, one thing for the last question with the bioethics of, people not having perhaps their chemo or something, I think at some juncture, we're going to have sites where you separate up a sick versus a non-sick, and potentially have independent sites that work on elective surgery for the not sick, and maybe just kind of separate them out to wrap up that part. As far as the testing, I mean, it keeps shifting because of a variety of reasons. One of the roles of the drive-by testing is to identify those who might have the illness, which may make a difference in whatever setting they work in, so that they know if they have the diagnosis without kind of putting a burden on any particular entity, such as the potential for exposure of a sick COVID-19 patient or potentially sick whose diagnosis is not yet known, to an outpatient office or to the emergency department, where the potential for exposure is just a lot greater. And so if you minimize that risk with a one-to-one with in the car and then kind of the drive-by, perhaps you can minimize that. And there are changes as you find out things such as if for example, these individual swabs sometimes have to go into a media that incubates and that you use for testing, and there are sometimes shortages of this or that. And this is why many times there are changes to testing protocols, and as it becomes more urgent to know, and unfortunately sometimes have to prioritize who might get tested. And it's evolved also as the disease has where it was just in certain geographical areas, and then you could trace back who was more likely to have COVID-19. And now as we see community transmission, there are differences in why we might test certain people.
I am getting a lot of questions about how people can help in the community due to this PPE issue. People are saying certain neighbors are sewing like crazy with regard to cloth masks. Can they use white vinegar as a disinfectant? Are these really useful and valuable substitutes for PPE? And are we, how else can we mobilize the people who are chomping at the bit in isolation, where one of the things that I would recommend is whatever it is that your solution that you're trying, any problem that you're trying to attack and solve, make sure that that doesn't undermine your initial social isolation. So we don't want someone to solve one problem by creating another problem. So if everybody could touch on final thoughts of how everyone in society can help in terms of doing their part, because we all together can really make tremendous inroads. I would love to hear final thoughts from each of you with regard to that.
I think from the PPE standpoint, there are obviously a lot of dire needs in many cases, and many times it depends on the individual hospital as far as, for example, some are accepting donations, but donations of unused supplies that have been approved, such as N95 masks that were unused but were used by a different store or a different clinic that now is not kind of mobilized and so forth. As far as things that people can make, the answer is it depends, because your intention is great, but certainly some kind of mask is better than no mask at all. But whether it'll actually afford the protection if that's all you have, that's not as clear sometimes. So, and whereas there are other things that one might need to consider if there's a shortage of other things like gowns and kind of those face shields that you might see. And these are things to consider in ways that we never thought about. And I think the mobilization will depend on where the communities are, what is accepted by the local hospitals or the EMS and so on. And each of these will potentially have their own ideas on what is accepted and what they would kind of not be able to use at the moment.
Dr. Van Rhijn?
Well, I would echo what Cindy said in terms of the fact that we're not really sure if the homemade masks are really going to be sufficient to protect the healthcare workers. They may be more useful in a family situation if somebody's actually trying to cover their own cough. For instance, you would use a tissue, you might have a mask or something if somebody's coming to care for a family member who has coughing, but I think the jury is really out on as to whether or not they're going to be that effective. I think one of the things we can do, though, as a community is, we have lots of social media and we have FaceTime and internet, and we can check on our friends and see how they're doing. There's lots of ways that we can help friends who might need supplies or might need an errand run for them, or just might need to talk to somebody if they feel that they're isolated. And I think there are ways that we can do that, even if we are in relative physical isolation. So we shouldn't forget that we are still connected.
Dr. Omer?
Yeah, so I'll take the last 1 or 2 minutes to that's something coming up on the questions, and I in the interest of time, I didn't address the herd immunity thing that people were talking about. Especially, there was an op-ed by someone who used to be, a physician who used to be affiliated with Yale up until a few years ago in an adjunct position, and sort of that is a version of a former UK model, which said that let everyone get infected who's not in the really high risk group, and we'll develop a herd immunity, and the rest will be protected. So it's not, those of us who both work on the quantitative side and also in the field find that a little bit concerning, to be honest. You'd notice that a lot of these ideas are not coming from infectious disease epidemiologists. Even if there is, people who contribute as, for example, nutritional scientists, et cetera, that's, the contributions, and everyone has a voice. But those of us who actually deal with these issues, not, starting 3 months ago, have a little bit of concern of push toward that strategy. That's why the UK government abandoned that strategy. I do feel that there is, and my understanding is there should be something coming out in the New York Times, focusing on some of the more mainstream approaches. I think our focus should be how do we safely reduce these restrictions based on some of the things that I mentioned. There are no shortcuts there. One of the things that I will come back to what my colleagues mentioned is there are these two outbreaks. One outbreak is of the virus, and the other one is for misinformation. And one way of dealing with this is to sort of filter the information, but also a lot of scientists who were very passive on social media have taken time, and God knows those of us who are actually doing active research don't have the bandwidth to do this, but go on social media, do events like this. My Twitter handle is Saad Omer 3, OMER 3, and sort of you feel free to follow me. And there are many others who are even sort of more effective in conveying factual information.
Thank you so much, everyone. You're all amazing. And to everyone who's following here, we're going to be having more Yale events. We'll send out a link to this video, hopefully later today, to the attendees of this event. And you can certainly forward it to anybody who think it would be helpful so that they can get good information. I have a litany of questions. I ask all of you to email me at my email again is Yale Alumni Health Network @gmail.com, Yale Alumni Health Network @gmail.com, and I can forward to the different panelists if you have a preference of a question. We'll figure out a way to get those to you. Jan has a Twitter page at Yale Health SIG, at Yale Health SIG. I'm on Twitter at Jamie Wells MD, JAMIEWELLS MD. You can independently follow any of my personal accounts from Facebook to LinkedIn to whatever to get questions to me. If you forget the email address thereafter, I will get anything to the panelists that anyone has a request of. So I can do that. And again, our email is Yale Alumni Health Network @gmail.com. There are so many questions. Things are evolving. We hope that you are empowered by the information today. You can absolutely take helpful steps. Try to be in the moment to focus on the good things that do abound in life. It is a wonderful opportunity to check in on neighbors. If you have a skill set or service that you can voluntarily used, every person has individual value that can contribute to helping this problem, whether if you're an entertainer, make people laugh. There are so many modes of communication for that. So the mental health, physical health, economic health, all of these things are intertwined to get us past this critical point. And we thank you all for attending. And again, it's not over. There are going to be other events. We're going to probably do another one. And in addition, you can reach out, Yale Alumni Health Network at gmail.com. Thank you so much.